ago, CAT was formed to address the needs of non-insured or precariously insured people living with HIV's access to treatment problems. And it's both sad and inspiring that we still need to continue to do this work 20 plus years later. But that is the reason why CAT continues to be relevant and important to exist, and that's why our partnerships have to step up and continue the fight. So Blue Door Clinic was formed in 2019 after a number of strategizing and planning activities from the community, and it's the brainchild of many community partners working together. So CAT played an instrumental role. I remember Alejandro and myself at the OHTN think tank one day, and we were championing this agenda. And fortunately, after a little while, it actually met with a lot of resonance from a lot of community partners, and we started to build this idea together. So, unlike some other initiatives that are widely recognized, non-insured people, racialized communities, newcomers are always marginalized in our sector. I guess in similar ways that Black women and ACB women are marginalized and continue to face the struggles that Maureen talked about. So, we have inequitable access to treatment, to resources, and support. And that obviously has a profound impact negatively on our community's health. So the Blue Door Clinic was established, but we established with mostly in-kind pro bono services and donations from our partners. So in order to look at that model and see how it works and make a case for it to be relevant and recognized by the sector so we can get the equitable resources to continue these important services, CAT championed this research study called Beyond Blue Door, because we wanted to really document and evaluate how the clinic works and make a case for serving our communities in a more long-term, sustainable, effective manner. So we are very proud today that many of our colleagues on the team are here. But first, I wanted to recognize our co-investigator team, Eugene. Eugene, maybe you can stand up. Josephine. Alejandro. Is Renee, and our community collaborative partner lead, Jeff from Sherborne. And anybody here from, is Simran here? No, and we also have a research associate, Kania, with part of the team, and Michael. Yeah. And then help me point out other people that I missed, but and OR actually also is a program associate with the project. And then Sarah, our clinic nurse coordinator. And then Vicky, who is a capacity building program coordinator. So we wanted to share with you some of the lessons we've learned from the research. So I wanted to invite our teammates, Alejandro and Josephine, to come and share the presentation. So Josephine will start. I think Dr. Josephine doesn't need a lot of introduction. Any of you here doesn't know Josephine?
Of course, there are all kinds of people who don't know me. That's okay, you'll get to know me later.
Okay.
Okay, so Mary earlier had supported us and did the land acknowledgement. So at this moment, instead of repeating what had been said, I would just like to invite you to take some time to think about your relations with Indigenous communities and what's your role and what's your commitment towards reconciliation. So Alan had identified team members and partners who are in this room. And our report actually had this information there that you can see. This is a project that is actually involved many people, and it's because of the commitments that we're able to carry this out. As Alan said, we're often very marginalized, especially people who are living with HIV, and on top of that, if they don't have citizenship status or PR status, they're very marginalized. And compared to other programs that's funded by the government, the Blue Door Clinic that is very inspiring is also constantly being marginalized. And I was involved with this study, and I had to say that every time I conducted the focus group, I was so touched. I just want to give everybody who work in the Blue Door Clinic big hugs, even though I don't know some of you. So this study, the research goals is actually to generate knowledge on the determinants of HIV-related health disparities as experienced by people living with HIV with precarious or no health insurance coverage. And in the study, we have heard really a lot, and we'll talk a little bit about that in the findings. The other thing we want to do is actually to generate evidence-based strategies. What are we going to do about that in terms of policy as well as practice? And also to evaluate Blue Door Clinic. Very often innovative ideas come out, innovative programs go out, people are dedicated and volunteer their time. But when it comes down to policy, if we don't have evidence, then people would just say, well, that's really a nice idea. So Blue Door Clinic is actually a research study that is based on implementation science so that we can see what happens, what works, and what didn't work, and what need to be improved. So the research design, we are guided by principles of social justice and equity, also about community being accountable, collective empowerment, as well as meaningful involvement of people living with HIV, and critical health emotion framework. And this framework actually recognizes that we are all together. Individual and collective health are actually intertwined. And so, and also how healthy we are is actually related to a lot of structural and social factors. So the mixed methods that we use focus group, individual interviews, and questionnaire. And we have two phases of the research. The phase one is on people who experience insurance coverage. Either they're precarious or they don't have coverage. And phase one will engage PLHIV who actually had not used the clinic. They don't have to have used the clinic because we just want to find out what had happened in their lives that actually lead to this. And then phase two actually will engage individuals who actually had come through the Blue Door Clinic and access the service. And both phases also involve service providers who some of them were with the clinic and some of them were not. And this is the reframe design, and it's based on this model that we're able to actually capture the evidence. So the Re-Aim Clinic actually looks at the reach. We're able to actually reach the participant that we want, and as well as how effective the program Blue Door Clinic as an intervention is about. The other part is about adoption, and adoption is really about the idea of Blue Door Clinic had it been taken up, and how is that really being carried out as an intervention. Implementation would include all the processes that's engaged in it. So that would include how services have been provided and how people have experienced the services, and a lot of the details about the everyday running of the clinic being captured. And then the maintenance is really about how do we go about sustaining an intervention. A clinic as an intervention is actually really quite innovative. And I was very inspired by the clinic and the team. And we take in consideration of the geographic, socio-political issue, as well as the systemic issue that is happening. So very quickly, I'm going to talk about phase one results, and then Alessandro will be talking about phase 2. So in phase 1, we engaged 30 persons living with HIV as well as having precarious health coverage. We also had engaged 21 service providers who are serving people who have precarious coverage and living with HIV. And you can see this seemingly quite complex diagram, but this diagram is actually comprehensive in a way and is in the report. And we find out that there are multiple dimensions to what is happening in people's life. Their experience, their health equities or inequity experience is related to policy and structures. And the policy and structures are not only when they're in Canada, there's some pre-migration policy that actually affect them. But then, of course, coming to Canada, that is supposed to be a fairly affluent country with supposedly good social welfare security system, people were still experiencing certain kind of gaps and challenges. Then the health service and access provision, and we can see that many of these are intertwined in a sense that you see that the blue dots are actually the narratives and the stories from the people living with HIV, and the red ones is the service provider. So stigma and discrimination in society before migration and after coming here continue to be something that affect people accessing services. They also had lack of sustainable resources. Other things as identified by service provider as well as people living with HIV are actually quite aligned. It's really about gaps in coverage, but on top of that, there's the challenges about accessible services in terms of language barriers, in terms of cultural inclusive type of services. Then there is an intersection social determinants, and I still recall, and I was quite touched by the kind of challenges that people actually face in terms of the kind of discrimination and violence that they face before they came to Canada, discrimination they still continue to face here, as well as a lot of the challenges that is related to mental health. Mental health became a big issue during the conversation. And of course, as a lot of the work that Kat focus on, there's also the part that actually identify the strategies. What are the kind of things that actually support people to be resilient, and what are the strengths that can, strategies that can bring and empower people? So now I'll ask Alessandro to come up. Oh, you are the next person.
The two quotes you wanna.
Really? You go ahead.
So we won't, the quotes are all in the report. So I think the first one speaks to the mental health needs that Josephine talked about. Oops. The second one was echoed by the service provider about the challenges about accessing to healthcare due to a lack of insurances. But the third one talked about the resilience strategies and the community support that has been critical in addressing some of those issues. We will talk about that later more. So basically, I'll talk about the quantitative findings of phase 2, and then Alejandro will talk about the qualitative findings. So in phase 2, which is the service evaluation of the Blue Door Clinic, during the period of the research, we serviced 159 clients. And then these are the focus group clients, their narratives and experiences Alejandro will talk about. So of the 159 clients, you can see that there is a majority of them are come by visitor visa, significant amount by study permit, 11% has no official status, and then at least 2/3 of them are having non-English as their first language. There's a huge proportion of Latinx communities and overwhelmingly male. And most of them are gay or bi identified. So about 1/3 of our clients are first or recent diagnosis. And then the main purpose of accessing the Blue Door Clinic is to continue the treatment or to start treatment. So during those time, you can see that the clinic is a very collaborative and holistic approach to supporting clients because we do a lot of we are being referred to by a lot of agencies, other health providers, 27%, other ethno-racial ASOs, a service organization, also mainstream ACE organizations. But there are also people who find us online and self-refer themselves. Some of them are referred through the lawyers or legal services. And then you can see that we do a lot of outward referrals to different ASOs. Mainstream ASOs actually mostly people with ACE Foundation because they provide a lot of practical support, and also that's where Latino Positivo Ontario is housed. Right, so there's a lot of connection, and a lot of our peer navigators for the clinic actually comes from PWA and Latino Positivo. So that's how people are connected. So that's our main outward resources, referral as well. And then I think this doesn't show very well in the color, but the majority of people is already on treatment. But most of them are also at risk for having treatment interruptions. And we actually end up sometimes, our original goal was to just provide like about 0 to 3 months support, and then we thought that we can find people bridging ongoing primary care, but that didn't turn out to be what we found because of the fact that the immigration system is very, very slow and has a lot of barriers, as well as the fact that part of our study period also overlapped with COVID, which makes things a lot worse. And then there's also a lack of HIV primary care services in the community that we can refer people to. So all of these factors are reflected in the fact that a lot of time it will take at least 4 to 6 months to be able to help people find long-term primary care. And then sometimes people are with us for more than a year and a half. But the most significant thing in terms of health data that like a lot of the more clinical community looks at is whether we're actually improving people's health data, right? So you can see from this right-handed graph that like the proportion of people with very low CD4, which is a very compromised immune system, actually have decreased significantly, and the number of people who have higher CD4 actually increased. And then also the proportion of people who attain undetectable viral load increases significantly. And I would say out of the 12% who has not attained undetectable viral load is because those are the people we refer them out within 3 months or sooner. So we actually didn't have time to do a follow-up viral load. So some of them I would expect to be undetectable as well. My apologies, this is not showing up very well, but in your report there is. Let me see what that means. So I think this is the immigration status and the source of medication. So basically, I think a lot of people are onboarded for compassionate medication. The blue bar on the right chart is the 79% of people access compassionate medication through our support. And then 51% on the red bar on the right is people who didn't have any access to begin with, and then it decreases to 0. So now I will invite Alejandro to talk about the experiences of people through the focus group in phase 2. Any question about the numbers?
Clap if you're awake. Yay. Thank you. Yeah, so I'm gonna talk a little bit about who we engage. So we really engage 31 people live with HIV as well as 35 service providers. I'm not gonna go through the full slide. You do have the report, so I will encourage you to read it. But I think out of this, a lot of the people that we see at the Blue Door, and Sarah can speak to this, we saw 51% of visitors to Canada, and it comes a lot When you really think about it, like people from countries like Mexico, they can come here without a visa and then they want to stay. And then other countries like Chile also, they don't need a visa to come and stay for 6 months. So these are the people that are coming here to look for like better assistance, to look for better medication. And then when they get here, it's like it's not as easy when you really think about migration and the things that you hear outside of Canada, you basically are picking tree money and then you're getting your housing and then there's a harsh reality when you get to this country and there's no housing, there's no job, there's no supports, you don't know where to get your medication. So like Alan said earlier, we do have people that through word of mouth hear about Blue Door and it's something that's important to know. We never really advertise. And I think Jeff can remember that we never really did outreach, we never went out, it's like, oh, we're open. And just because of that, we have all these people that you can see here, so we have visitor, people with study permit, people that are refugee claimant, as well as people that come with a work permit. So, and then 77% of our clients, English is not their first language. And we're seeing a lot of male identified clients, as well as 10% female and then 3% non-binary. And then in terms of where they're coming from, just to allude what I was talking earlier, so 58% are from the Latin community, 60% are Black, African or Caribbean, 16% are Asian, and 6% are white. And then from the service provider, we really engage people that does primary care, around 53%, and then clinic partners, as well as 8 service organizations, because we really do rely on these partnerships, and then really Blue Door is here, like Alex said earlier, because of the partnership, because of the in-kind support, and really the willingness and the commitment of the providers, the case managers like Simran and Five House, and everybody that put their heart out, like Sarah and like the coordinator we had before, that they really is not about money, it's not about position, it's not about advocacy, but it's really to help a community that's in need. And then we can see it with these numbers, and then you can see even more once you read the report. So, and then we have a client base with a percentage of like 6 months prior to the study. And let me go next. And these are some of the strengths that we hear from participants about the Blue Door. So it's human, person center, and affirming care. And this is something that I think for the people in this room doesn't come as a surprise that healthcare should be done this way. But when you really leave the Blue Door and then when you really hear the feedback from other places that we refer them to after for primary care, it's not always the same. Or if you're going to like an immigration medical exam, it's not always the same. So participants recall the care, how Blue Door provides services, how it looks at them holistically, not only medically, and they really treat them as a whole person, not as a number, not as a UCI number, for those of you that know what that is. And so, when you know, you know. And then the service provider really, they're committed, compassionate, they're flexible, and they're very professional. I think I'm just trying to make this a bit hard hitting because it's very important to don't forget that we're treating human beings, that we're working with human beings. And I think from the speech that Maureen gave early, we really need to show up. And this is one of the ways that we see not only service provider, but community shows up for one another. This is a quote, oh, I should have put the quote earlier. So this is a quote from one of the participants of the person that are living with HIV. Another strength of the Blue Door is the multi-sector intersectional approach, and I think we've talked about this and like the new partnerships that are coming on, and then really will really portraying the strengths that are in the sector in one place. So I'll give you some time to read this slide, but I really want to talk about it. Just everybody shows up, everybody, and then we now know where to go when. At a time when Blue Door wasn't there, people didn't know where to go. And it was always like a capacity building for service providers. And then now we see more and more we can have access, but it's still very centralized in Toronto. Then we have another quote from a service provider. Oh, and then immigration physicians. That's next, I think. And then continue the peer-driven linguistic and culturally relevant of care is very important because we do have peer navigators that support the client to really express themselves while they're there, and it's not calling interpretation services, so it feels more human, like we said in the slide earlier. to have that connection, and usually because as Alice said, we're partnered with PWA, so they have the same, sometimes the same bridging care from Blue Door when they go to PWA, so you're not going into these events of another organization or retelling your story and why you're there, but they're really peer navigators and the case managers, they really are the heart of this organization and of Blue Door. And then we communicate via phone, email, text, because we know that a lot of people don't have a Canadian number, don't have access to work for a while, maybe their own house, maybe with their couch surfing, and then, so we are flexible to meet the needs of the community. So yes, another quote. You can read it on the, I'm just trying to, you can read it, I'm encouraging you to read the report, because it's a beautiful, beautiful report. And then spotlight that we want to say is the peer power. So participants stress the critical importance of peers as they navigate complex health systems and services. Peer navigators of the clinic play a unique role providing language interpretation, support, and connecting clients to community. And participants were intentional volunteer, and many stated that supporting their community was deeply connected. So like I said, it comes from the heart, and it's important that peers are embedded not only in Blue Door, but I think in every healthcare service out there. Adaptability and responsiveness. So I think when COVID came, is that my timer? I feel like it goes pretty fast. If you know, you know. So when COVID raised us, we really had to adapt, and we had a drop in, and then after it was like by appointment only. And it really exacerbated people's issues because they didn't know where to go, and then it was like the unknown. So really it speaks to the flexibility of the Blue Door to raise up to difficult situation, which what was convened in the first place. And then integrated knowledge, translation and exchange. And then finding from the Blue Door group fed back to the steering committee to support integrated knowledge translation and exchange and make real-time practices, adjustment and quality improvement. And because of that, we have the nurse coordinator position, and I see Sarah here, and a clinical case management for follow-up. We do have EMR tools on clinical summary, and then we do have the Blue Door capacity building project. And I see the coordinator at the end of the room. And then some of the challenges that we are facing in the operational capabilities due to lack of sustainable funding. The most significant challenge, like we don't have core funding for the Blue Door Clinic. Like we've been saying all day, everything's donated in kind and a few funding sources. We do have resources restraints such as space limitation, we have staff turnover, resource limitation, and we have mandated restriction to care for non-plus partners for people that are living with HIV. So because we only see people that are living with HIV. And then another challenge is like outreach, resource material, and clinic promotion. Just a lot of the clients said we don't do enough outreach, we should have more pamphlets in different languages, and both clients and service providers highlighted the need for more online social media and free resources. But to do all this, we do need core funding, money, yes, money. Great, and then this is a quote for another focus group. And another challenge is system and structures. And I'm laughing because I think when Alan said from the beginning how CAD started and then now Blue Door started, so really not much have changed. We still see a lack of access to non-HIV specialists, shortage of MDs available and willing to take precariously insured client, shortage of HIV experienced providers, changing limited time on compassionate access on certain HIV meds, and lack of available resources to support client challenges around mental health, precariously housed, and employment, and other social determinants of health.
Thank you, Alejandro. So now we come to the recommendations. So we grouped our recommendations into targeted audience groups. So we first wanted to talk about recommendations for affected communities. I think as Alejandro said, it's kind of discouraging to think that in 20-some years' time we're going full circle and things didn't get much better. But I think the things that are better, is that we have a communities now. We have strong community leaders like Maureen, like Alejandro, who are at the forefront of advocating and building systems, for our communities. And so we do see that hope and we do see that response with the capacities and the passion and the resources. Although the health systems itself is still very inequitable and the resources are still very limited. But I think that one of the areas that I think Blue Door Clinic could do more is really to support and mobilize affected communities to maximize their leadership roles to co-create health services that are culturally relevant and accessible. So we wanted to make sure that the leaders and advocates from affected communities can engage in co-designing, guiding, and evaluating the development of linguistically inclusive, culturally safe, and community responsive services. And then be able to secure the resources they need to maximize the roles of peers and affected communities in actually promoting and delivering the services to them. And that's not just in roles of ambassadors or advisors, but really actually in all the capacities that they are really capable of. In terms of service providers who are not from the affected communities, I think the Blue Door Clinic lessons have really provided a very inspiring example to for service providers to tell them to invest more in holistic healthcare practices and approaches that focus on trauma-informed and mental health competent care. So I think as Alejandro talked about, the affirming and compassionate holistic approach is really important, especially for people facing complex intersectional challenges. And then I think providers need to really strengthen and develop more of their awareness and critical understanding of how the unique mental health needs of this community, as well as building capacities and practice competencies specific to the realities of uninsured, precariously insured people living with HIV. And then for service planners, which they actually hold a lot more power than we thought, because as frontline service providers, often we are at the mercy of our management or our clinic director or our executive director or the hospital administration, how much service we are allowed to provide, right? So we wanted to make sure that the service providers are on board to ensure the sustainability and scalability of successful models such as Blue Door Clinic. So first task for them is to secure core funding, obviously, so that we can continue to provide the excellent services that we've been providing. And that is not limited to just paying doctors and nurses. It's really about having holistic case management support, peer navigation, interpretation, supplies, and administrative support, because all of the personnel involved and all the resources are important to our clients. And they need to secure resources to strengthen cheaper practices, because a lot of times people get paid on a salarium or minimum wage when that's not equitable to the kind of services and the impact they are able to contribute. So that people are really supported to play in co-designing and co-delivering roles in the services of Blue Door Clinic. And then they need to help support development of online service resource listing, navigation tools, digital initiatives to strengthen the informational access. One of the reasons that I know that a lot of the clients actually said that we should promote our excellent services more, but I guess our own internal fear is that we don't have capacities to meet all the needs that already coming to our door. So that's part of the reason. So we want to break away from that catch-22. We are very proud of our services and we do want to promote it. Just that we want to make sure we are in in the shape and capacities to be able to continue that services. We don't want to just, get more numbers to show, but not really maintain the qualities of the services we provide. And then we actually think that we do really, want to replicate and scale up the clinic model at different locations, because we have people coming from Aurelia, from London, from other places in Ontario to really seek care from us. And then we wanted to further promote the integration of wise practices related to Jupiter allyship, intersectional approaches, and community responsive, trauma-informed practice changes to other service framework that is not just for HIV, but for other marginalized communities' health needs. And finally, for policymakers, there's basically two key recommendations. One is obviously to increase the resource support for innovative models of supporting care, such as the Blue Door Clinic, but also really to support multilingual service provision in all the partner agencies so that they can maximize the reach and the effectiveness of their services. And then also to expand the service mandate of community health centers, because community health centers are supposed to serve uninsured population, but they are not allowed to serve visitors or students. So that kind of trapped us in a very unconscionable state, because we basically have to wait till the students graduate and become statusless before we can serve them, or people lose whatever partial insurance or precarious coverage they have before we can service. And then finally, we really want to build allyship with our co-advocates and partners across the health sector to lobby for a publicly funded pharmacare program to ensure universal treatment access for all Ontario and all Canadians in need of life-saving and life-sustaining treatments, regardless of insurance coverage. So hopefully, with all your support and working together, we can achieve this. Thank you very much. So we also wanted to just take this opportunity to let you know that by next month, by October, the Blue Door Clinic is actually going to be relocated from Regent Park Health Center to Casey House. So you want to tell us something more? This is your place now.
Sure. So I think October 2nd, we will be moving here, and the clinic, instead of being only Monday, now